Hello, my name is Aisha Abed. I'm a third-year family and community medicine resident here at Penn State Milton S. Hershey Medical Center. Today I want to take some time to discuss a study regarding diabetic screening. Now, as we all know, diabetes is a national health concern. Here in the United States, approximately 9.3% of individuals have diabetes. Now, most of those individuals, half of them actually, have clinically manifested complications at the time of diagnosis. So when they present to either the emergency room, the clinic setting, or other rooms of the hospital, they often have a complication. Now, these complications include myocardial infarctions, blindness, renal disease, all of which may be preventable. So it's crucial that we find lead time in order to prevent these disease sequelae by implementing either pharmacological or other lifestyle changes. Now, we have certain screening guidelines in place to detect diabetes. However, they often miss the high-risk individuals who are often prone to diabetes for one reason or another. Now, two of the most well-known guidelines include the ADA, or the American Diabetes Association, and the USPSTF, or the United States Preventative Services Task Force guidelines. Now, the USPSTF is very brief in their guidelines. They revised their 2008 guidelines and put out new guidelines which stated that adults age 40 to 70 who are overweight or obese should be screened. Now, the ADA is a little bit more specific in their guidelines. They suggest screening all adults who are overweight or obese and who have additional risk factors. And these risk factors include hypertension, physical inactivity, obesity, amongst others. Adults who are age 45 or older should be screened regardless under these diabetic screening guidelines.
Hi, my name is Shala Ahmed, and I'm also a third-year resident at the Penn State Hershey Medical Center. I'm going to be talking about the guidelines. As Dr. Abed had mentioned, there are several guidelines out there that help to screen for diabetes, two of which, the major ones, include the American Diabetes Association and the United Preventative Task Force. Both of these guidelines are fairly thorough in screening for diabetics. However, they're not as comprehensive as we think. For example, the current guidelines do not characterize the younger population that is affected by diabetes. To evaluate these screening guidelines, it makes sense to look at the high-risk groups that are identified by the guidelines themselves. For instance, family history is a known predictor of the likelihood of diabetes. It is known that having a parent who is diagnosed with diabetes mellitus increases the person's risk of developing this disease 1 in 7. If you have two family members that are diagnosed, or two first-degree family members that are diagnosed with diabetes mellitus, this increases the risk in 1 in 2, which is quite high. The expert committee actually recommends screening or earlier screening of these individuals who have a positive family history. However, they don't actually mention the exact age. There are several other studies that have shown that those diagnosed or those members that have a family member or first-degree relative that is diagnosed with diabetes have a chance of developing the disease 8 to 12 years earlier than an individual who does not have a family history. Therefore, it does make sense that these people should get high-priority screening. However, as I mentioned before, the guidelines don't specify the appropriate age of when the screening should be done. The United Preventative Task Force does not include any subpopulations, and the ADA and the American Association of Clinical Endocrinologists recommend testing, but they don't actually recommend when. It is likely, unfortunately, that many of these patients have a positive family history and are not diagnosed with diabetes until the age of 45 and older, which is quite late. Similarly, we know that other risk factors include ethnicities include ethnicities that have a higher rate of developing diabetes, more notably those who are Native Americans, non-Hispanic blacks, and also Asian Americans. Asian Americans are at a higher risk of developing diabetes at a much lower BMI. In fact, the American Diabetes Association adjusted their guidelines to screen Asian Americans at a BMI of 23 or greater, which is much lower. However, the United Preventative Task Force guidelines do not mention ethnicity at all. Therefore, you can see that although these guidelines are quite extensive and helpful in screening, they do lack in certain areas.
So, based on the information that you've just heard, it's obvious that we need a better system to diagnose the 8.1 million asymptomatic diabetics in America and the 76 million with prediabetes. The USPSTF outlines screening guidelines previously focused on coronary risk factors and now on obesity. However, it doesn't really include the high-risk populations, which are often spearheaded by a younger age group, especially the individuals less than 40 years of age. Now, this is largely due to lack of data, unfortunately. We just don't have enough information comparing the ADA and the United States Preventative Services Task Force guidelines. We also don't have data regarding physician use of these guidelines. So in conclusion, on one hand, allowing there to be better tests out there which cast a wide enough net would increase sensitivity and increase anxiety. On the other hand, it would also increase healthcare expenditure. So based on all this evidence that we brought up and some more which you'll find in the article, we came up with some few guidelines and pointers to consider when screening adults with diabetes and younger individuals with diabetes. So hopefully some of this information will cast light on the need for high quality studies and focus on earlier screening in otherwise asymptomatic individuals. Our hope is that we can inevitably control this endemic. Thank you.